Hi, it's Jessica DeMassa with WTF Health. What's the Future Health? You're joining us for a special series that I'm hosting about COVID-19 response from different healthcare leaders in the health system. So joining me today, I have Rahul Rajkumar. He is the Chief Medical Officer and Strategic Vice President at BlueCross BlueShield of North Carolina. Rahul, it's a pleasure to have you with us.
Thank you so much for having me here today.
Thanks. So I reached out to you initially because I wanted to talk to you. I was really impressed. In my Twitter feed, it seems that BlueCross BlueShield of North Carolina was one of the very first health plans to reimburse telehealth at Parity. And so I reached out to you for that. And before I ask you those questions about reimbursement, telehealth, and adoption there, I do want to pause for a second because also recently, within the last day or so, BlueCross BlueShield of North Carolina announced another really assertive reimbursement policy around COVID-19 treatment. So now you guys are joining some of the nationwide plans like Cigna, Humana, and United Healthcare in terms of reimbursing not only the testing costs associated with COVID-19, but also the treatment costs in full. So tell me a little bit about that decision first, and then we'll jump to the telehealth start. So where did this come from? Give us a sense of, why it was that the organization, why the health plan decided to cover this in this way.
Yeah. Well, first of all, Jessica, thank you so much for having me here today. And, we are living through an extraordinary time, and it is extraordinary for all of us at every level. This is a national emergency, and it is a challenge not only at the national level, but for the state that we serve, North Carolina, for our 3.8 million members. And our highest duty as a health plan is to protect our members when they are in the healthcare system, to help them in health, to walk with them. And in a time like this, that takes on a different type of meaning. And we take that responsibility really seriously. And so the decision that we announced yesterday comes from that acknowledgement of responsibility and our core mission and our values to serve our members, to improve the quality of care that they receive and protect their health. We don't want cost sharing or financial considerations to be a barrier to anyone seeking care for coronavirus disease. And this is a statement of our values. It's who we are. And that's why we decided to announce the waiver of cost sharing for all COVID-19 related treatment.
I mean, truly, this is such a wonderful gesture. I mean, especially as, we all know how healthcare costs can be debilitating even in the best times when someone gets really sick. So I think it's commendable that Blue Cross of North Carolina has stepped in this way in order to make that less of a burden on people. As you're looking forward in terms of how this all pans, I know those measures are in place until June, I believe, for you as well as most of the other carriers. As you're looking beyond that, is it too soon to tell how long these changes might stick?
It really depends on what happens. Like everybody else, we're following the epidemiologic curve very carefully. We have been following it for the last 3 months. And I think in 60 days' time, we will reevaluate this policy depending on what's happening nationally and in North Carolina. We hope, like everybody else, like all Americans, like everybody in the world, that we're able to bring the epidemic under control and pivot to a public health approach of widespread monitoring, testing, surveillance, and try and restore our lives to normal. That's the long-term game plan, but certainly we will reevaluate this policy.
I want to talk about the other side of it as well. I know obviously putting the member at the center of this was the focus behind the decision, but also on the hospital side of it, there is something to be said there as well. I believe you guys are reimbursing at the full rate with the hospitals. Is that right?
Yeah, so we will pay at the full allowed amount. And what that means is that the hospitals will not have to collect the member cost share. So ordinarily, when a hospital collects the member cost share, we've all gotten bills from providers or hospitals. They don't collect 100 cents on the dollar, but in this case, they will be paid 100 cents on the dollar for the member cost share. So one of the other aspects of this is that we're looking for different ways to support our network providers, that have, quite frankly, are doing heroic work across North Carolina and have stepped up in dramatic and previously unimaginable ways. So canceling elective procedures, elective surgeries, they are heroes in this, and supporting our members, providing care. I'm a physician myself, often at personal risk, and we could not be more appreciative of the care that our providers provide to our members, and we're looking for ways to support them through this.
I mean, I know that there are growing concerns among hospitals, especially those in rural areas. And I don't know if you can speak to that at all about, how some of those rural hospitals are faring in North Carolina in terms of, moving those elective procedures, out into the future so that they can care for those who are sick due to the pandemic, and as they're looking at staying in business and keeping their doors open, any impact that you've been able to make there and helping kind of ease those concerns and bridge that gap?
Yeah, I mean, our policy applies to all hospitals. So half of our state is rural. In fact, more than half of our state is rural. And so that was very much on our minds when we announced this policy, that we, in particular, wanted to support our rural hospitals. But I think that, the coronavirus pandemic has been a shock to every player in the healthcare system. So hospitals, independent providers, and also us as a health.
I do want to go back to telehealth, and I want to talk about that a little bit more with you. Like I said, I was really impressed when I saw that you guys were looking at this in such a proactive way in terms of kind of tearing down some of the barriers to implementation that we've seen in the past. So obviously there's been national legislation that has made it possible for medical practitioners to practice across state lines now, where that didn't exist before. But really, and the payment side of it has always been another barrier in terms of, reimbursing at parity. So I guess if you could talk to me a little bit about the role you see virtual care, different telemedicine solutions or remote monitoring solutions playing in all of this, as you are trying to expand your delivery network and help support, the care providers in North Carolina. Tell me about the role of virtual care and all that.
Yeah. So it's amazing how quickly this came together. I mean, so let me just spend a minute talking about the world of telemedicine pre-coronavirus.
Mm-hmm.
So, we like many other plans, we provide we pay for telemedicine services through certain vendors like MD Live or Teladoc. We also pay for telemedicine services, had paid for telemedicine services in certain limited situations. In the midst of a pandemic, with a disease that is transmitted like the flu, through droplet, it's critically important that we move as many patients out of the healthcare system as we can. So we don't. One of the most important parts of social distancing is not having people go into the healthcare system if there's another way that they can talk to their doctor, right? And so we don't want people around other sick people.
Mm-hmm.
And it's not just enough to do that for people that have suspected coronavirus. Like, we need every doctor to be able to flip the switch to virtual. And so, paying for telemedicine more broadly is something that we have been thinking about and likely would have done. It just would have taken us longer. I believe the first case of coronavirus in North Carolina was on March 4th. And so we saw that and were aware of how fast this was evolving in other parts of the country. And we looked at the epidemiologic curve and realized that this was probably the most impactful thing that we could do, is flip the switch on telemedicine. And so it took one meeting, and we said, we're doing this, and we're going to pay for telemedicine services for all providers, all specialties at parity with face-to-face. And so that means if you're a cardiologist or an oncologist, you could tell all of your BlueCross patients, stay at home, and we will see you virtually. And that could be through FaceTime, it could be through Skype, it could even be over the phone without a video visit. Mm-hmm. Doesn't need anything fancy, and you will get paid by BlueCross just as if you had seen the patient face to face. Another dimension to it is that we're rely on all of our network providers, and we want them to be around, and we want them to be financially healthy and solvent, right? And so if you think of, in particular, rural providers and independent providers, they need to be able to keep the doors open. And everybody has to do their part in order to make sure that they can keep the doors open. So Medicare, CMS has really stepped up and is paying for telemedicine services at Parity, has done an advanced payment program. But we believe that our part in this is what we have done, is to pay for telemedicine at Parity for all providers.
And as somebody who's been involved in this side of the industry for a very long time and can speak to the challenges there, and I'm sure there are many people whose jaws dropped open when you said it took one meeting, because there have been a lot of meetings over the course of years to attempt to scale up telemedicine rapidly and have this kind of broad uptake. And while this is not the way that we wanted it to happen, here we are. And I wanted to ask you, I guess, as this is unfolding, I mean, and you had said you were close even before the outbreak to adopting these different reimbursement policies around virtual care and telemedicine. You were close. And here you are now. And as you're, I guess, looking at how this is unfolding and you're watching your members utilize, whichever format of telehealth they're using, while you're watching the clinicians, integrate and adopt as well. What do you have your eye on in terms of metrics or, any of like the performance indicators that after this is all over, would, I guess, maybe have weight with somebody at a BlueCross plan in terms of saying, you know what, we've flipped the switch on, we're not flipping it back off? Because I think that among us, that's one of the things that we're looking at is, are these changes going to stay after this epidemic is over? Or, are we going to go back to the way it was where things were done and not at parity, reimbursement was not at parity, things with all these regulations come back. So what are your thoughts on that? Is the switch going to stay flipped, and what are you looking at to make sure that it does?
I'm sort of talking out of school here for a minute, but it is my hope that we'll be able to leave the switch on for telemedicine. But I think I'll pick up on something you just said. We need to use this opportunity to study it carefully. So if you think about telemedicine pre-coronavirus, in healthcare, we like to study things. Mm-hmm. And so the reason that it would have taken us more time is that we wanted to study the impact of flipping the switch on total cost of care, on the quality of care that our members receive. Mm-hmm. And we weren't sure what the impacts would be on quality of care and cost of care. Right? And so we thought it was something worthy of testing, worthy of study. And that's probably the direction we would have gone in. But in a world where you have a pandemic and you're trying to protect people and keep them out of the doctor's office, out of the hospital, this is as close to a no-brainer as you're going to get. And so we'll flip the switch on, and now we'll study it. So yeah. It's a unbelievable opportunity to study this important question in health policy. So some of the things that we'll study are the effect on utilization patterns for specific types of members with specific types of diseases. So do we see people with chronic diseases using this more? Is it more acute care conditions? Really interested in what types of providers use telemedicine. Is it distributed evenly between primary care and specialty care? What other types of innovation do we see in the use of telemedicine? So our policy is wide open. So, theoretically, a hospitalist could round on a patient that's hospitalized remotely, right? And we would, for the professional fee component of that, we would still pay. Do we see that type of innovation in healthcare delivery? There are obviously procedures that are harder to do remotely. We're open to innovation in that space. And we're really interested in how this is used, how it impacts our members, the cost of care, quality of care, and how our members perceive it. And we've already engaged an evaluation team that's going to be looking at these questions really carefully. And so you'll see a lot more from us on that.
Good. We'll be curious to hear about that. Are you evaluating? I mean, it sounds like, and correct me if I'm wrong here, but as you're defining telemedicine, it sounds like you're talking about the doctor to patient interaction over either, like you said, phone or video. Are you also looking at remote monitoring? I mean, there's this industry, it can, if you start to expand your definition of it, it can go pretty broad. I mean, so there are things that people can have in their home to help them monitor chronic conditions. I mean, you had even touched on, B2B telemedicine, where it's, a doctor providing rounds in a hospital. I mean, so are you guys looking at other aspects of this as well? Tell me a little bit about that.
Yeah, so we are, but I think a lot of that work is going to be done by the providers themselves. So on the delivery side. So if you think of what it takes to treat a patient, to diagnose a patient, and then treat them, just interacting face to face in the way you and I are is maybe the most important thing, to be able to talk to the patient. But there are still parts of the physical exam and elements of the visit that we can't accomplish over Zoom unless we have other tools, right? Mm-hmm. So you could imagine if you were the doctor and I was the patient, what are the other tools that you would need, in order to round out the visit and deliver a full spectrum of care? And we think that now that we've flipped the switch, we're going to see a lot of that innovation on the provider side.
Okay, and so you're looking for the providers really to take the lead there.
Yeah, I think so. So things like accomplishing parts of the physical exam. Mm-hmm. How do you collect patient's temperature, vital signs? All of those things are possible, but it requires a different workflow to do it through a telemedicine visit.
Yeah, absolutely. No, and I'm sure I know of so many different health tech startups who have different devices and different types of, sensors, wearables, you name it, that can help with all of that stuff, even those that are integrated into your phone. Pivoting just a little bit, talk to me about 2021 and what you see after hopefully this is all over. And I know I'm asking a lot in terms of, gazing into your crystal ball, but, knowing health plans and really knowing anybody in healthcare. I mean, we're planners. We want to mitigate risk. And, I think there's a concern not only about providing safe, effective care, but there's also a concern, ultimately, as we've been talking about reimbursement, about costs and what ends up happening. And I know 2021 people are already looking at as, those elective procedures that get put off this year, they're probably going to go into 2021. What happens then? What happens to all of these costs that were incurred for treatment of COVID-19 now? Where does that dollar flow and end up? And even the costs related to some of these other changes that employers are going to have to consider as they reevaluate the health plans that they've put in place to take care of their employees. At a big BlueCross plan, how do you guys even start to think about this? Have you even started? And if so, I mean, where do you start?
Yeah, it's a great question. So in the same way that we're studying telehealth, we're seeing another unprecedented shock to healthcare delivery, which is that all of these elective procedures are being canceled or postponed, right? And it's not just that. There's so many patients with chronic disease that would ordinarily be making trips to their doctor's office that are not making those trips now. And what is the effect of that? How does it affect health outcomes? For a whole spectrum of diseases, we're beginning to study these questions. My own prediction is that we'll find, as you said, that many of these elective procedures will get rescheduled. So they'll happen eventually, but many of them will not. And one of the possible outcomes here is that we'll discover that some of these things may not have been necessary or helpful in the first place. So it's really an incredible time to study the utilization patterns of healthcare and what do we need to do and what can we do differently? What can we do better? I think the other thing that we find here is that we already, pre-coronavirus, have been on a journey of partnership with our providers. So we are implementing the most rapid move to value-based care in the country. 8 out of 10 of the major healthcare systems in North Carolina are in our value-based program, which we call Blue Premier. And it's a true partnership between BlueCross and these providers to manage total cost of care and improve the quality of care that our members receive. And living through a crisis like this has only deepened that sense of partnership with these providers. And so we are doing things now that I would never have imagined us doing, like, helping providers procure protective equipment or supplies, things that they're not able to source easily. And so I think of this as, your neighbor's house is on fire, pick up a bucket,
Right.
That's what one has to do. I see us coming back to these relationships with an invigorated sense of partnership after this is over.
Well, that's exciting. I mean, and like you said, I think, healthcare is forever changed in this country, and I think the relationships around it as well. And so, again, thank you for your time, and truly, again, kudos to Blue Cross of North Carolina for the it's almost heartwarming. Like it's like the right thing to do in terms of the different policy changes that you've made in terms of being able to offer the coverage that you have to your members, and also to help your doctors out.
Well, I appreciate the opportunity to talk about it, and thank you so much, and stay safe.
Yeah, likewise. Thank you. I'm Jessica DeMassa. That's Dr. Rahul Rajkumar from Blue Cross Blue Shield of North Carolina. He's the Chief Medical Officer there. Thank you again for joining us. This conversation about COVID-19 and what different healthcare leaders are doing to help mitigate the crisis, whether it be from a reimbursement standpoint or from a health technology standpoint. More interviews like this one can be found up on my YouTube channel. That is at youtube.com/WTF Health. Thank you once again for joining us. It's a pleasure to speak with you, and we'll see you guys real soon. Stay safe, everybody.
Thank you.
Thanks.